Good afternoon, everyone, and thank you for joining us for the second talk in our READI Research Policy Impact Series focused on the basics, Health Policy 101 with Amy Rohling McGee, President of Health Policy Institute of Ohio. Before we begin, we'd like to share a bit about the CTSC. The Clinical and Translational Science Collaborative of Cleveland is a collaborative among Case Western Reserve University and its affiliated hospital systems, the Cleveland Clinic, Metro Health, University Hospitals, and the Louis Stokes Veterans Administration Medical Center. We aspire to be a catalyst for high-quality clinical and translational research, both locally and nationally, by changing the culture and environment of biomedical research, sharing resources and expertise, and streamlining the research process to move translational research from bench to bedside into the community. Let's learn about today's presenter. Amy has served as the president of the Health Policy Institute of Ohio since 2010. With her leadership, HPIO has developed a reputation as a trusted source of data and evidence-informed policy analysis. McGee has more than 20 years of experience in management, government relations, policy development, strategic planning, stakeholder engagement, coalition building, and communication. Her prior public sector experience includes work in the executive branch of state government, focused on policy issues such as mental health, health insurance, health system improvement, and Medicaid, and service in the state legislature as a Legislative Service Commission intern in the mid-1990s. Private sector experience includes 5 years as the executive director of the Ohio Association of Free Clinics. Amy earned her bachelor's degree and master's degree in social work from The Ohio State University. The floor is yours, Amy.
Hello, good morning, or actually good afternoon now. I am going to share my screen here. Let's see. Oh, it looks like I might need, oh, there we go. Got it. All right, can you see my slides? Can someone just let me know for sure?
Yes.
Okay, great. Well, I very much appreciate the opportunity to be with you today. I have a great deal of passion for the field of health policy and want you to know how important the work you do is to informing the policymaking process. I'm very glad to be able to share a little bit about what we do at our organization, make you aware of some resources that might be helpful to you in your research, and hopefully spark some interest among all of you for getting engaged in the policymaking process. I'd like to invite you to please, in the chat, just type in what health policy issue or issues you find most interesting. And let's see, I need to figure out how to look at the chat. Maybe someone could share some of the topics that are in the chat. I have too many screens open.
Happy to help. So
Thank
I see
you.
DEIA, so diversity, equity, inclusion, and accessibility, education and training in healthcare and in research.
Okay. Great. Well, we will definitely talk about some of those themes. And also, I hope we will be able to make you think about health policy in a broader way too, as a result of what we're going to share today. First, the mission of the Health Policy Institute is to advance evidence-informed policies, and that's where the role of research comes in, generating that evidence that improve health, achieve equity, and lead to sustainable healthcare spending here in our state. Now, policy can be both public sector and private sector. We focus on public sector policies, and I will share some examples of what we mean by public sector policy throughout the presentation. Policy in the public sector can be crafted at the federal, state, and local levels. Can be crafted through laws and rules and regulations, as well as things that we often don't think about as policy, such as guidance issued by state agencies, resolutions passed by members of the General Assembly, executive orders issued by the governor, and ordinances passed by city councils. So there's lots of different ways that public policy is crafted. Many times we think of the legislative process as being the primary way. It's important, though, to consider all of the other ways in which public policy is created and enacted. Much of our work focuses on state policymaking in both the legislative branch and the executive branch. We are doing more work now at the local level as well, in particular working with a couple of communities around mental health and substance use disorder issues. But most of our work traditionally has focused on state policy making process. We have been heavily influenced by the work of researchers who years ago estimated the modifiable factors that influence our health. While we often will think of clinical care as being a core aspect of our overall health, it's the other environments in which we live that are much more significant contributors to our health. So of course, access to high quality clinical care is critically important if we're sick, if we experience an accident or injury, if we have a chronic health condition. It's where we live, where we work, whether we're able to recreate safely, whether we have clean air to breathe, that are much more significant contributors to our health. And all of those systems and environments can either support or inhibit our behaviors or choices we make, which also contribute to our overall health. So we take this very broad view of health, and our analysis and the data that we compile reflects that. I'm going to share with you today 3 main publications that we've recently produced that would be helpful for you to review as you consider getting more engaged in health policy. So the first of those publications is Ohio Medicaid Basics, and this has just recently been posted on our website. It hasn't even been more widely disseminated yet. We produce Ohio Medicaid Basics every 2 years, so that as a new General Assembly begins in our state legislature, other folks can get up to speed on this important program. Right now, the Ohio Medicaid program covers about 3.6 million Ohioans. About 30% of our population has health insurance coverage through Ohio Medicaid. It's a significant share of our state spending, especially when the federal dollars that come to our state for the purposes of paying for Medicaid claims is included. It's about 39% of our state budget. And right now, the Ohio Medicaid program is going through a lot of changes. There are new Medicaid managed care contracts that are in place, recently put in place, and are creating some changes for people who receive Medicaid coverage. And then also there's a redetermination process that just recently restarted. And so that's taking a lot of focus within the Ohio Department of Medicaid here at the state level. There are important differences between the Medicaid program and the Medicare program. Even though their names sound very similar, Medicaid is a state-federal partnership where the federal government sets some general parameters and provides funding to states to serve people who meet certain eligibility criteria. and most of that criteria is related to income. On the other hand, the Medicare program is run solely by the federal government, funded by the federal government, and is primarily there to serve older adults and people with disabilities. There's also differences in the types of services that are covered by Medicare and Medicaid that are important to know. And you can dive further into all of those details by looking at Ohio Medicaid Basics. We will also be hosting a webinar on Medicaid here in the coming weeks. Please feel free to sign up to receive notices from HPIO of our publications and our educational forums, and you'll get more information about that publication or that webinar when it's happening. We have, you can sign up for our email distribution list at hpio.net. Now, just last week, we released the most recent version of Ohio Medicaid Basics. I'm sorry, not Medicaid Basics, the Ohio Health Value Dashboard. I'm going to share some of the data from the Medicaid. Oh my gosh, I'm stuck on Medicaid. From the dashboard with you this morning. Again, this is another publication that's available on our website, so please feel free to download that and spend more time with it. The dashboard is a publication that we have created now for 5 iterations. So every 2 years, we've updated the data in the dashboard. There are metrics in the dashboard related to all of the systems and environments that impact our health. So again, going back to this pie chart that illustrates the modifiable factors that influence our health. Ohio ranks 44th on health value. This is a composite measure of Ohio's performance on population health outcomes and healthcare spending. After compiling 5 editions of the dashboard over the past 10 years, it's clear that Ohioans continue to live less healthy lives and spend more on healthcare than people in most other states. The health value rank is based on state performance on all of the metrics that are in the population health and the healthcare spending domains, with both domains weighted equally. Ohio is somewhat unusual in that we rank in the bottom quartile for both of these domains, which is what pulls us down in terms of our overall health value rank. Taking a look at our performance on the contributing factors helps us to understand Ohio's strengths and challenges. Access to care has been consistently a strength for Ohio. It's our best performing domain. But access to care is necessary, not sufficient for good health. These other drivers are also important, including everything from the quality of care we receive and the capacity of our local health departments, to the air we breathe, the food we eat, and how safe we feel walking in our communities. There are over 100 metrics in the dashboard. They're organized by 7 domains. So the 5 contributing factor domains that are here on the left, and then the 2 value factors, which are compiled or composited, or sorry, they're pulled together to create the health value rank. This edition of the dashboard is a classic glass half full, glass half empty moment. It's half full because our rank has improved over time from 47 to 44. And when we look at trends for individual metrics, we had more improvement than worsening, all in the wake of a global pandemic. However, we generally need to be cautious about looking at rank over time because it's relative to other states. We're hopeful that as we look at this over the long term, we will continue to see Ohio's performance improve compared to other states. On the other hand, the glass is half empty because we're still in the bottom quartile for health value, population health, and healthcare spending. In fact, Ohio and West Virginia are the only states that are in the bottom quartile for both population health and healthcare spending. So I've covered a little bit about Ohio Medicaid basics, a little bit about our health value dashboard, and now I'm going to move on to the third piece that I wanted to share with you today, and that's the equity profiles that are a part of the health value dashboard. Getting to health value requires systems and environments that allow every Ohioan to reach their full health potential. However, many Ohioans continue to face barriers like poverty, food insecurity, and racism and discrimination that prevent living a long and healthy life. The equity profiles in the dashboard examine where there are gaps in outcomes among groups of Ohioans and analyze the barriers that contribute to those gaps. These have been a part of the health value dashboard since 2017. Many of the disparities measured in the equity profiles are driven by unjust historical and modern day policies. For example, decades of racist housing policies like redlining and present day practices like predatory lending have resulted in neighborhood segregation, concentrated poverty, and disinvestment from communities of color across Ohio. As a result, Ohioans of color are much more likely to experience harmful community conditions, such as food deserts and unsafe, unstable housing that affect health. There are equity profiles that break down the data for Black Ohioans, Hispanic and Latino Ohioans, Ohioans with disabilities, Ohioans with lower income or less education, and then new for the 2023 dashboard, we also included an equity profile for LGBTQ+ Ohioans. We see the direct and indirect impacts of policies in the data. Data from the 2023 profile for Black Ohioans shows large disparities in conditions in the physical environment. Things like housing cost burden, food insecurity, and air pollution are much worse for Black Ohioans than for their white peers because of policies that have shaped communities. The equity profiles also measure how many people would be impacted if we were able to eliminate these disparities. Here's an example showing how many Ohioans would be impacted if we close the gap in child food insecurity. New in this iteration of the dashboard, we examined where there has been progress on metrics that we've measured in the profiles since the first profiles in 2017. We saw the greatest improvement in metrics related to unemployment, heart disease mortality, inability to see a doctor due to cost, high school graduation, and child poverty. I want to talk a little bit about this specific metric. Remember how we started by talking about how policies can create barriers to health? policies can also reduce disparities and improve health. One example of that is in the percent of Ohioans who are unable to see a doctor due to cost. Back in 2013, there was a large gap between families with lower incomes and families with higher income. Almost a third of lower income families reported having to go without care because they couldn't afford it. Looking at 2021, that gap has been reduced by almost 2/3. I'd like to invite you to come off mute here for a second and let me know if you can think of any reasons why we've seen that improvement since 2013. Anyone have any thoughts?
The Affordable Care Act.
Medicaid expansion.
Yes. You win a prize, a gold star.
Yay.
Yeah. Yeah, so policies that were put in place in the Affordable Care Act, like expanded Medicaid eligibility, as well as pandemic-related coverage protections that have been in place for the last 3 years, has significantly reduced the percent of Ohioans who are uninsured and can't afford care. They've also narrowed gaps in access for Ohioans of color, as you can see in these graphics. So continuing to explore our glass being half full, when we look at specific metrics, we see that overall, Ohio improved on 24% of them. Much of that improvement was the result of policy change and dedicated efforts to improve outcomes. I would invite you to download the Health Value Dashboard, and in particular, look at page 8, where we share a little bit more about the types of policies that have contributed to improvement in these areas. So moving on from where we have been and where we are today in terms of outcomes, we think it's important to use this data to motivate and propel action. So what we've done in this version of the dashboard is focus on the glass half full by highlighting ways we can build upon our strengths, the strengths we already have present here in our state. We have a lot of options. A lot of times, folks will remark that there's nowhere to go but up here in Ohio, because on so many metrics, we're in the bottom 2 quartiles. But we have lots of opportunities on which we can build. In particular, we can work to strengthen our workforce. We can foster mental well-being, and we can improve healthcare effectiveness. In particular, we can build upon recent success in attracting employers in high-growth industries to strengthen the workforce and reduce poverty. We can build upon our expertise with and our community response to the addiction crisis to become a national leader in behavioral health. And finally, we can build upon strengths and access to care to reinvigorate approaches to improving outcomes and controlling healthcare spending. We highlight 9 specific examples of policy changes that can move us forward in all of these areas. All of these examples have evidence of effectiveness, can close gaps in outcomes, and are relevant to our strengths and challenges here in Ohio. So what I'd love to do now is see what questions you have for me. I've just shared like some very, very high level information and resources for you. And I'd love to hear what your thoughts are about the information I've shared so far, and what questions you have for me.
We do have a few questions in the chat. Does the decrease in
Okay.
child poverty track national trends?
I'm sorry, could you repeat that question again? Hello?
Does the decrease in child poverty track national trends?
Yes, it does track national trends, and was the child tax credit was a significant contributor to that reduction too. That was a policy change that happened at the federal level. Other questions?
Yes, so I have a question. Hi, I'm Mary Louise, and
Hello.
I'm just curious because when I watched the Ohio channel, they're talking about rolling back like some of the Medicaid benefits this year. Like that's been a major, like rigorous discussion. So we're like saying, oh, we've made these improvements during the pandemic when it was very liberal. So
Mhm.
we're already saying that that's an improvement, but yet we're going to go and I'm sure the net is going to be cast a lot wider. We never do anything in the middle, right? We're one or the other, and we're going to cast that net so wide. And I'm like, we're going to catch people who probably really do need it.
Right.
Line, and what's going to be placed to prevent us from rolling back? Are they going to wait until we roll back and then do something?
Mm-hmm. Yeah, so that's something that we're going to be tracking very closely over the next year or so to see what the impact is. And that's not the only policy change that could impact health. The other is that SNAP benefits, which are food stamps, those are also going back to pre-pandemic levels as well, and could have an impact on health too. So any of those changes that went into place during the pandemic that resulted in improvement is something we're going to want to track over the next several years to see what the results are. So talking a little bit more though about Medicaid redetermination. So during the pandemic, during the public health emergency, the federal government gave states extra money for the Medicaid program, and then put in place a condition, which was that states could not disenroll anyone during that public health emergency. So over time, over the last few years, the percentage of Ohioans who are enrolled in Medicaid has just continually increased because nobody has been disenrolled. Now, there are some people in that group who maybe temporarily needed Medicaid coverage because maybe they lost a job or their job shifted, and perhaps they will be able to access other health coverage from an employer. There are other people, though, who still need that coverage. And one of the concerns is that the paperwork that goes out, like their addresses may have changed over the years. The paperwork may not reach them. Often, I would venture to say always, the paperwork that comes from Medicaid or from county JFSs is difficult to understand too. So it's, whether the big question is who will fall through the cracks. The providers are also there's a role for providers in this because people who are providing care to people on Medicaid coverage will need to make sure that their patients know of the changes that are happening and work with their patients to either re-enroll them, keep them enrolled in Medicaid, or re-enroll them right away if they lose coverage in all of this. And to make matters even more complicated, I mentioned that there are new Medicaid managed care contracts that have recently gone into effect. So people who have Medicaid coverage are getting kind of bombarded right now by lots of mail from lots of sources. And it's very difficult to navigate what you're supposed to do when it's very difficult to navigate the systems involved. I will share the one piece that will likely be helpful for people in all of this is that the federal government has increased funding for navigators. So these are people who are employed to assist folks with navigating all of these systems. So at least that funding has been increased and that capacity has been increased, but we are still concerned about what the impacts are going to be on people who have that coverage now.
Thank you.
You're welcome. Other questions?
We did have a question from someone who had to leave the call.
Okay.
The question was about data for AAPI and if that was available.
Oh, yes. We do include data for Asian American Pacific Islander populations when it's available. There are limitations to when it's available. And then also there are often limitations in the disaggregation of that data because there are lots of other populations within that larger population. And there may be disparities that impact some groups more than other groups. And we know that the existing available data doesn't get it that many times.
Thank you.
Mm-hmm.
And what are your thoughts on a researcher? Let's just assume that this is their first time interacting with or involving policy in their research program or studies in terms of using that as their North Star. How could they use the health value dashboard without being too overwhelmed with all the data? What would your recommendations be for them?
Well, I think I would recommend focusing on those areas that I mentioned towards the end of my presentation around how Ohio can improve and thinking through whatever work you're engaged in through that lens. So, I mean, there are, but I would also add that that's not an exclusive list. For example, we know that tobacco policy and policy related to other nicotine delivery devices is incredibly important to health as well. And there are many policy changes that could be implemented to reduce tobacco use. So I would start with the list of policies that we elevate in the dashboard, those 9 example policies, although I'd also consider other areas where we are in the 4th or 3rd quartile on a particular metric and consider focusing on specific policies that could improve that particular metric. A great resource that we often tap into is called What Works for Health. I'm just going to type that in the chat. It's produced by the University of Wisconsin Population Health Institute, and they have aggregated research findings from numerous sources and rated policies and strategies by level of effectiveness. So that's another good tool that if, for example, you're interested in what kind of policies can improve adult smoking rates here in Ohio, you could look at what works for health, as well as numerous HPIO publications, which also discuss that topic.
Excellent, thank you.
I put our website in the chat, and as I said, there's lots of resources there. Another issue that we have done recent analysis related is infant mortality, in particular looking at the social drivers of infant mortality. So not so much that clinical care component of the issue, but all of the social, physical, economic environments that impact disparities in infant mortality and birth outcomes. We just put out a kind of an overview brief on that topic, and then two briefs specific to to housing and to education, as well as drivers of health outcomes. And then we will move on to do further analysis on employment and transportation as well, and elevate policies that address those areas that can improve our overall rates and disparities in infant mortality.
Thank you for bringing that up, because I think that that is a piece as we move toward more community-focused research. What are some best practices for integrating social drivers of health, those considerations, into kind of more clinical focused research? How can we marry the two? And I don't expect for you to have like the magic answer to this, because I think, largely it is still being figured out. But what are some best practices for integrating the two?
Well, I guess the first suggestion I have is to understand the linkages that have already been established through research, and then also think about and learn about where there is evidence emerging, but not yet complete. We've done that in the social drivers of infant mortality work, and I'm just going to pull up an example to illustrate that. And of course, I'm not putting my hands on it. Okay, here we go. Let me just share my screen again. Okay, so here, this figure that shows the relationship between housing and infant mortality, it shows where there are direct linkages already established, like where you see those lines and arrows heading over to the right, and where there are not, but there are hypotheses that there are linkages. So for example, toxic and persistent stress under the negative effects on health and equity, there are linkages established through research from toxic and persistent stress to poor birth outcomes. Similarly, there are linkages between poverty and certain behaviors like alcohol, tobacco, and drug use. So I think just understanding what the body of research tells us about where there are those linkages, and acknowledging, even if you're conducting research that's related to clinical care, acknowledging how all of these other factors may be impacting the desired outcome as well. That's an important first step. And then I think a second step would be contributing to the research, exploring the areas that have yet to be, where the linkages have yet to be established as well.
I have a question. On page 7 of the dashboard, at the bottom of it, there's a section called policies to drive improvement, and it outlines 3, possible areas where we could improve healthcare outcomes and equity via policy. And I was wondering if there's data on, I guess, and then at the bottom of the dashboard, there's kind of like a comparison of how Ohio ranks in terms of spending and health value according or based on other states.
Yeah.
So I was wondering, are the policies that are outlined as like potential improvement areas, is there data showing that they work in other states?
Yes. Yeah. So all of those policies to drive improvement that are at the bottom of pages, let's see, they're pages 5, 6, and 7. All of those are evidence-informed policies. So we've either they either are identified as such on what works for health, or we have found other evidence of their effectiveness.
Yeah, are there like links or something to like how these policies are instituted in other states or how they were implemented elsewhere?
We wish that there was that, because a lot of times folks will look at the graphic at the end. I think it's the one on page 28 that you're referring to.
Yeah.
And they'll say, well, what's Hawaii doing?
Yeah, right.
What's Utah doing?
And what's New York doing? Yeah.
Right. And interestingly, when we years ago, we were doing some work on the social drivers of health. And one of our ideas was that let's contact the states that have lower disparities in infant mortality, like Black-white infant mortality, and see what they've done, because it's great that their rates are better. What are they doing right? And when we did key informant interviews with people in those states, across the board, none of them knew what they had done.
Right.
Like there had not been like one specific thing that had been implemented or enacted in that particular state that had led to that improvement.
Right.
Likely, it's a combination of factors.
Yeah.
That influences those outcomes, and the same is likely the case when you look at health value and population health and healthcare spending, that it's likely a combination of factors. So, it's hard to think about Hawaii being at the top without thinking that having nice weather and an environment that's conducive to lots of physical activity may be playing a role. Same thing with Utah. Like if there's just kind of this general culture around being outdoors and being physically active, also culture around drinking and smoking too. There's other states that kind of perplex us more. We're just not sure what's going on there, that they're doing so much better than us, like Texas, for example. We don't know. So what we do instead is look at kind of the combination of policies that, when put together, can increase the likelihood of achieving better health outcomes and healthcare spending.
Okay, thank you.
Any final thoughts for the group?
I did have one other slide that I wanted to share with you in closing. So let me just go back to my presentation slides here. Well, first, I just wanted to acknowledge our funders. We're a small nonprofit organization. We're located in Columbus, Ohio. We were created about 20 years ago by a group of foundations that came together because they felt that there was a need for a nonpartisan and independent nonprofit to analyze health policy issues, to be focused on data, to be focused on evidence, and inform that entire policymaking process. We are registered as lobbyists. However, we don't lobby in the traditional sense of lobbying, in that, like if you think about a pharmaceutical company that is lobbying on behalf of their company to make sure that government policies are in line with their business and their profitability, that's not the type of lobbying we do. We're focused on championing the cause of improved health and sustainable healthcare spending, achieving equity, so much different. We also don't take positions on specific pieces of legislation. We let the data speak for itself. We will elevate options, policy options and examples, like those pages in the dashboard that we were just discussing, where we elevated 9 evidence-based policies that could lead to improved health value. But we stopped short of saying, you should pass House Bill, whatever number, staying more on the side of education and analysis. So it's these funders that enable us to do that work, to be independent, to be nonpartisan, data focused. I wanted to share, though, that there are a number of ways that you can be involved or engaged in the policymaking process. So, of course, policymakers, whether they be serving in the executive branch or the legislative branch, they exist to serve us. They are elected, or at least the leaders of those branches are elected to represent us. They need to hear from their constituents in order to create policies that are reflective of what their constituents and the population that they serve want. So would encourage you to engage in writing letters, sending emails to your elected officials. There are websites that you can go on to look up your legislator. So you could even just type into Google, like, how to find my elected officials. And you usually type in your address and your zip code, and it'll tell you who your US senators are, who your congressional representatives are, and who represents you in the Ohio Senate and the Ohio House of Representatives. So knowing who all of them are, knowing what kind of legislation is pending at the federal level and the state level are important first steps, and then engaging in writing letters and making phone calls when an issue is really important to you and to the people you serve is a great way to engage in influencing the policymaking process. You can also, depending on what your role is, you can engage in district-specific data analysis. So if you are meeting with a legislator that, let's see, I'm trying to think of a specific example. Like if you could do some analysis of zip code related data for that particular legislator's district, that can have a much greater impact than just using kind of statewide data. Oh, and I wanted to mention that too, that while our data is focused on the state level, many of the metrics that we use in the health value dashboard are also available in the county health ranking, which is kind of a similar tool for analyzing data related to health. Doesn't include the healthcare spending side, but you can pull some county data using that tool as well. Also, if you're working with a particular program, engaging policymakers in the work of that program is a great way to build relationships even before you're asking for something. So inviting that legislator, city council person, county commissioner to come tour, come to an event, visit the program, get to know the people who are working in the program and the people who are served there is a great way to build relationships. Just important to remember that these folks are there to serve us. They often want to hear from us, and they should hear from us regarding how the policies that they're creating impact real people here in Ohio. So I would encourage you to get more involved, and would also encourage you to sign up to receive information from our organization and stay in contact with us going forward. I think that's all I have.
All right. Thank you so much, Amy. Invaluable information, and love that final slide. These are things that we can start today even. So that is fantastic.
Great.
And speaking of other things that we can do today, you can schedule a READI consultation at spark.case.edu. Put some research, equity, accessibility, diversity, and inclusion into your research programs and studies. No better time to do that than today. You can sign up to attend future programming and join our listserv, and even review some CTSC DEIA resources. We'll give you a couple of minutes to head to your next meeting, some virtual commute time or real commute time, engage in some meaningful activity that will help you commute back to yourself. And that's a phrase coined by Dr. Jennifer A. King here at CASE. And thank you so much for joining us. Please connect with us on social media, send us an email. We'd love to partner on a future event. And we just would love to hear your feedback as well. Have a great afternoon, everyone. And thanks again for joining us.